something very common to speak of, and I think it opens a lot of open questions about the techniques and procedures and the treatments and the results, of course. Now, when we speak about conservative surgery, first of all, we have to speak about conservative surgery in gynecologic surgery. Gynecologic surgery is something that is facing every day maintaining the right head up on fertility. And of course, being a surgeon, I had to put in the list of the possible procedures ovarian cystectomy, partial ovarectomy, myomectomy, metroplasty, fallopian tube surgery, and hysteroscopy, of course. They are all procedures and techniques that are able to affect fertility, even when they are done to protect fertility. So let's start with ovarian cystectomy. We know that cystectomy is a procedure which is in the hands of the gynecologist surgeon, and it is quite common for the surgeon gynecologist to do this kind of surgery, keeping an eye on the possibility that the fertility might be affected. This fertility might be affected by the production of adhesions, by bleedings during the surgery, by affecting the capsule of the kyst, which is also lining under the cortical of the ovary. And by doing this, of course, we are able, from one side, to catch out the cyst from the ovary, but also we can produce some damage to the ovary, and this is very important to keep in mind. So first of all, it is important to operate with the right technique by stripping the capsule, by doing very small damage to the cortical of the ovary, and of course by coagulating and using the diathermy in a very small amount. This is always a compromise between having a bleeding and having the right hemostasis. The same happens when we touch the uterus, and the uterus, we know, is a site where we can find a very common disease, which is the fibroids. Fibroids can affect the uterus in specific sites, in the site which is called intramural, which is just in the lining of the muscle of the uterus, or subserosal, which is just outside the muscle, but still inside the peritoneal surface. Now, I don't know if everyone is very comfortable with anatomy in our audience, but it is important to follow in this figure that we have those fibroid, which are the white one, that can affect altogether this site. So let's imagine that we take out an amount like this on the right of that figure, which is something like around 12 fibroids. The bigger one was around 8 centimeters, the biggest one. So the largest being 8 centimeters, you can understand that when we take out all this amount of things, what we leave is a very damaged uterus, and we have to reconstruct it. There are techniques which are called metroplasty to do that. They are mainly used to do correction of anatomic malformation, but we use them also when we have to reconstruct the uterus. Now, those are all things that we can do by laparoscopy or by mini laparotomy or by laparotomy, depending on how big is the structure that we're taking out. But of course, the more we are going to be aggressive, the more we're going to leave sequelae. And what we mean with sequelae, sequelae is a word in Latin that gives you an idea that you're going to leave a damage on the back. The damage is fundamentally the fact that the organ cannot behave as it should during the pregnancy or before the pregnancy. So it's very important to try to reconstruct the uterus, keeping in mind that we have to keep the tubes open. The patency of the tube permeability is very important. We have to keep the uterus in his linings very strong, so the sutures that we put on are very important, the way we do it, but also the results that we have in terms of cicatrization, scar repair. It's a very important aspect of the whole problem. The same fibroid can be at the inner internal part of the uterus, in the endometrium, and we can see this on the left side here. This big fibroid, which is in the middle of the cavity, just where the baby should stay. This is a position where we have to use the hysteroscope to do the repair. So we do the removal of the fibroids, the myomectomy, just by cutting several pieces of this fibroid. And then when we arrive at the very, very end of it, sometimes we find that there is another part of the fibroid which is just inside the muscle, just attached to the muscle, and we have to repair also that. So at that point, what we can do is that by removing the whole fibroid, we can make some kind of damage. We can produce some kind of damage to the muscle, and this would give a certain dose of fragility to the uterus during a pregnancy, or it could decrease the blood flow to the endometrium, giving less hematic support, blood support to the embryo that is attached inside the cavity. So, as you might understand, sometimes we do a very nice job by taking out this huge fibroid from the cavity, but what we leave is an area which is less vascularized, it's less friendly for a pregnancy, and this can affect the fertility of the lady. And the same can be when we have to repair or to modify situations of occlusion, which are complete or just partial of the tubes. This can be due to also, in most cases, is due to the presence of what we call an extrauterine pregnancy. And as you can see here, this is an extrauterine pregnancy, which is in the tube, in the right tube. And to take out this, normally what we do is we just cut the salpinx, we cut the tube. But this is, of course, something that will affect the fertility of the lady. And from one side, it's the only thing that we can do. From one side, on the other side, we can just open the tube and try to take out the extrauterine pregnancy from inside, if this is possible, and leave it there to regenerate by itself. Now, this is not always successful, and of course, it brings a damage to the tube in all cases, and adhesions, and some decrease in the fertility of the patient and the chance to reproduce. Other things that we can do is, as mentioned before, metroplasty, which is the plastic of the uterus, which means that we reconstruct the uterus after finding the uterus with the malformation. Here you have a classification of the malformations that you can have, from septate, agenesis, unicornuate, didelphus, bicornuate, and all these are things that we can repair by laparotomy, by laparoscopy, or by hysteroscopy. But of course, when we do this, we leave a little bit of damage, and we have a decrease of the fertility. So fertility sparing surgery in gynecologic surgery, for benign reason, is something that can affect fertility, but almost always is still a very doable technique. What is a little bit different and very important is the fertility sparing surgery in gynecologic oncology. We know that most common gynecologic cancer in reproductive ages includes cervical, endometrial, ovarian. Of course, there are also other rarest form of tumor of the genital area, but those are the most common. When we say common, we have to keep in mind that we are in all cases talking about something which is a rare entity. Incidence for age less than 49-year-olds per 100,000 in cervical cancer is between 1.5 and 15. For endometrial cancer is 1.2 and 24, and ovarian cancer 1.6 at 16.6. And this I want to note is on the top of 100,000 individuals. So it is very important to understand that we are talking in all cases about rare form of tumors. Those are not the breast cancer or the colon cancer numbers, okay? The mean age on the other side of first pregnancy in Europe is between 30 and 34 at 29% almost. 35, 39 years old, 10%, and 40 and 44, we have a 2%. So we can understand that we have almost 40% of patients aged between 30 and 44 years old. And we have to understand also that a lot of these patients are seeking a pregnancy. Nowadays, there is a lot of chat about the fact that delayed childbirth increase the chance of illness and cancer, but at the same time, there are advances in cancer therapy, which means that we have better survival rates. And we have to keep in mind that this every year brings us new options to increase from one side the survival rate, but also the expectation of those ladies that are still thinking about a pregnancy after their disease. So the treatment of gynecologic cancer often results in loss of fertility. 10% of ovarian cancers are happening in women of reproductive age. 6% of endometrial cancers in women of reproductive age. And this is something that maybe not everyone was expecting. I mean, 6% is a small number. You have to put it in the context of endometrial cancer, which is the most common tumor in the menopausal woman. We would not expect to have these numbers for women in reproductive age, but this, with the advance and of the problem of obesity, of PCOS, of a situation that put at risk of hypoestrogenism, can bring you to those number in percentage. So endometrial cancer is quite well represented in fertile women. So the considerations when we treat a patient like this must be age, pre-existing fertility, what is their story? They have obesity, they have PCOS, they have been treated already for infertility, type of malignancy, understand what is the survival rate that we are going to offer to those women and to the family, okay? And treatment plan, which is surgical or hormonal or pharmacologic. So this can be also toxic for not only the woman, but her baby. Ethical considerations also are very much part of our job. We have to deal with new laws every 4 or 5 years. We have new guidelines in this case, and ethical considerations are not only ethical; they can be also religious for the patient. So I mentioned cervical cancer. One thing is that must be absolutely clear is that when we talk about fertility sparing surgery, in all cases, we are talking about very early stage of disease. So in the cervical cancer, the early stage of disease for us is what we call the carcinoma in situ and the stage 1 confined to the cervix cancer, okay? What is the confined to the cervix cancer? This is a macroscopic disease that we can find only in the cervix, in this very small part that I will point you with this red point here, okay? It can be outside or it can be inside here. The uterus is formed by 2 main parts. One part is the corpus, the body of the uterus, which contains the cavity, and the other part is the vaginal part, the one that is entering the vagina and is called the cervix. And we can differentiate between those 2 parts. And based on this differentiation, we can say that we can do some kind of surgery. We can do some kind of surgery that can protect the fertility of the lady we are operating on. So remember that only early stage cervical cancer is amenable, and the treatment, if we do a treatment, will be conization or trachelectomy. These depending on the stage, will be associated with another procedure, which is called lymphadenectomy. Now, I don't think that the setting here is so specialized to go through this, but I want just to remember you that this is a disease, the cervical cancer is a disease that can spread through distant route, but also, and more than that, through contiguous and lymphatic route. So it can spread through the vessels, but also through the lymphatics. And you have two structures, which are called the parametria, which are tissues that are surrounding the uterus and attaching it to the body, to the pelvis. And through this, we have a consequence of the structures. Most of them are fibers, but through those fibers, we can find linings of lymphatics, vessels, nerves, and lymph nodes. And so it's very important to understand that if we do a surgery on a initial stage of tumor of the cervix, we have to think about being, in all cases, radical. So unless you're treating a patient with an in situ carcinoma, which is really something precursor of the cancer, if you are dealing with the cancer, you have to do a procedure which must mimic a radical procedure. So trachelectomy is such a procedure. And by trachelectomy, we're not simply amputating the cervix. We are taking out the cervix, one small part of the vagina, the most proximal part of the vagina, and those surrounding tissue that comes back through the name of parametria. Now, in the parametria, we have also all the structures that normally are affected by radical surgery made through traditional ways like laparotomy or laparoscopy or robotic assisted. And so we have to be able to do this surgery by protecting those ureter, nerves, all this that gives to the patient the chance to keep a normal life in terms of micturition or bowel movements. So trachelectomy is really one option. The problem is that all these techniques that are condensed through the name of minimally invasive surgery and are maybe very famous because there is a lot of fuss about using robotics, assisted laparoscopy with robotics or traditional approaches and understanding what is the best approach to do that. I want just to remind you what happened just 1.5 years ago. We had a study which is called LAC, and this study went out not to demonstrate the power of traditional surgery, but instead to say that the minimally invasive surgery was absolutely the right choice and the final choice and was almost widely accepted everywhere. But through this study that was not mentioned and was not, I would say, designed to find out differences in terms of survival or relapse, we occasionally, fortuitely, found a very, very unexpected result, which led to reconsideration of the minimally invasive approach. What was this result? The result was that we had a 6-fold relapse rate in the patient that had minimally invasive approach if compared to the traditional approach. And this was really something staggering and very, very surprising for everyone. So we have to wait for further study before saying that those minimally invasive approach can be used on all operable cancers. And of course, this implies that if we are thinking about trachelectomy for a cancer which is 1B1, which means that it's locally advanced, even if very, very early, we have to think that we need to obtain a very, very precise consent from the patient, explaining all the pros and the cons of such a surgery. So I think that for cervical cancer, unless we are talking about really very, very early stage, 1A1, 1A2, which can be really dealt by conization and lymphadenectomy or by trachelectomy and lymphadenectomy, If we are talking also about 1B stage, I think that we have to wait for some more results from those new studies that are coming out with maybe some good answers for us. Of course, this doesn't mean that I don't believe in laparoscopy or in minimally invasive surgery. I am among those that believe that we are going to find a solution to this problem and we are going to continue using laparoscopy. But still, if we are dealing with a patient that is very young, keeping her fertility in mind, we have to think about the best option that could be also not only laparoscopic but also laparotomic. So it's not about the surgery in itself, it's about the way we produce this surgery, we perform it. So limited data suggests that oncological safety and favorable pregnancy outcomes following either vaginal, laparotomic, or laparoscopic trachelectomy are quite acceptable, but we have to remember that those are limited data. No difference has been found in 5 years survival in stage 1B1 cervical cancer treated with conization or trachelectomy versus lymphadenectomy compared with non-uterine preserving procedures. And here we have all kinds of surgeries, laparotomic, laparoscopic, and robotics. Significant reduction in blood loss, length of stay, less adhesion formation must be always kept in mind when we talk about minimally invasive surgery, because this could create a better future for the fertility of the patient and better obstetric outcomes. Now, let's keep an eye now on endometrial cancer. Now, if we go a little bit on this figure here, I will show you that when we talk about early stage endometrial cancer, we are talking about stage 1A. 1A, the stage that is absolutely spread only in the lining, which is called endometrium, and not in the corpus of the uterus. So we have to think about this first blue image here, which is the stage 1A. Normally, it's not presented like this. If one thinks that when we get in the uterus and we find only one spot that we can absolutely recognize by hysteroscopy being endometrium, which is cancerous, this is not, I would say, the normality. Normally, we find a widespread lesion which is having contacts with all the endometrium. It can be more or less spread in terms of geographic map, but normally it is quite a wide area that we have to deal with. So we have to keep in mind that not always what is our feeling that we could just resecate this and eliminate as a problem will be successful. So the gold standard we have to remember always for the staging is histopathology. So we have to think that normally the gold standard would be to give to the pathologist the whole uterus to be cut and to be sure that we are talking about a 1A, that are not embolus of tumor in the myometrium, which is the muscle which is behind the cavity. And this can be, of course, ascertained by means of imaging, but you have to think that the imaging can be 90% accurate, but not 100% accurate, okay? So the MRI, which is part of the staging, will give us an answer. Hysteroscopy will give us another big help in this, but we will face, in terms of our relationship with the patient, we will face a dilemma of being sure that we are giving the right and the final information to the patient, okay? So figure 1A is not always realistically and 100% sure. Varying regimens can be proposed in terms of controlling this tumor. We know that not only the surgical technique of retrieving the endometrium will suffice. We will need to add to this medroxyprogesterone acetate, Mirena, intrauterine devices system, and things like that. And this to create an environment which is against the tumor. There is also no consensus on the duration of and the follow-up, but what we know is that what we propose is normally to biopsy the uterus every 3 months. So no consensus on type, dose, frequency, duration, routes, and maintenance of the therapy. I put here a small schematic figure with the name of the drug and with what we can find. Normally, I would say that the last row is the most important. In endometrial cancer, we need at least between 400 800 milligram in divided dose daily of medroxyprogesterone. Megestrol acetate, Megase, I think you know it like this in Middle East, will be a dose of 160 milligrams. And the Mirena coil, sometimes depending if the patient is obese or not, we're going to use not 1 but 2 Mirena in the same uterus to assure that we're giving the right amount of dose of drugs. But this is not enough. We are going to see the patient every month and biopsy the patient every 3 months. So this is the only way to be sure that we're not losing control of the situation. And we have to be always prepared to propose a total laparoscopic or total abdominal hysterectomy, which is the gold standard for this disease, we have to remember. So this happens also when we are dealing with the complex atypical hyperplasia. This is a cancer precursor, everyone knows, commonly detected in PCOS. 30–60% of hysterectomies for complex atypical hysterectomy show at the end of the procedure, when the histopathology comes back, frank malignancy, and this must be bear in mind. So gold standard for this should be TLH or TAH, but we have patient asking for an option in terms of keeping the fertility. And so fertility sparing surgery and progesterone are an option after DNC and partial ablation of the endometrium. So the conservative management of endometrial cancer should be, first of all, accessorized by patient family being informed and aware of the risk. Should be sure that we are dealing with patient that is nulliparous, because if she already has baby, we have to really make sure that she understands the gravity of the situations. History of infertility, and of course, this is something that can be important in terms of explaining what will be her future in terms of seeking this new pregnancy. Histology. We keep in mind that we are dealing for questions of risk, because all our statistics are done with the most statistically common type. So we can speak only for endometrioid G1 disease. The size of the tumor should be never less than 2 centimeters in spread. And otherwise, the possibility, the chance that we are not detecting the full malignancy can be really not only difficult, but disastrous. Myometrial invasions should be always excluded. I will show you the next slides, which explain how to do that. And in our structure, in our institution, we have always an ART section that is available to give us counseling and to take in charge to the patient to make it possible to have as much as fast and effective treatment we have. The completion surgery should be always proposed as soon as possible when the pregnancy has come to an end. So the surgical management that I was explaining before is a 3-step procedure, a technique of tumor removal, removal of the endometrium surrounding the lesions, removal of the myometrium under the tumor, And by doing this, we have to make sure that we are not getting too near to the serosa, and we don't do any perforation, because perforation can give also dissemination of disease if we have a very aggressive disease. Magnestrol acetate, 160 milligram per day for 6 months. Biopsies at 3, 6, 9, and 12 months must be always negative before saying to the patient that now she's ready for a pregnancy. With this, a study with Mazzon that was done at my institution in Rome in 2010 gave us results of 4 on 6 patients with this kind of disease, stage 1A endometrial cancer, who achieved childbearing. So it was a 66%. Numbers are very, very low. You have to understand that we are talking about an entity which is very, very rare. So pharmacologic treatment for stage 1A endometrial cancer in literature from 1960 to 2010 gives us a response rate of 76% in terms of pharmacologic control of the tumor. The median time to response of 12 weeks. We are not going to have the patient stressed every day about this pharmacologic treatment. We have to know that we have to tell her that before 12 weeks, we cannot tell her that she's responding or not. But of course, we have to keep in mind that instead, if she starts bleeding and she starts having symptoms which are very, very suspicious, we have to be always ready to interrupt the course of treatment. The rate of relapse is 24%, and the response rate on retreatment after that relapse will be of 70%, a little bit lower than the response rate at primary treatment. So 20% pregnancy rate with 50% by ART, which with ART, I'm talking about FIVET and ICSI and all that stuff. 27% of those patients had an uneventful delivery with baby alive and well. Some had more than 1 pregnancy after that, but this is something that was related to that particular study that we did in Italy. And we leave now endometrial cancer and we enter another chapter, which is quite interesting, is the ovarian cancer, early stage always ovarian cancer. What are the options in terms of fertility sparing surgery? We have to think about the ovarian cancer as a very, very multiform entity. Staging of ovary is quite complex, based on surgery, based also on partially on imaging. And as you might understand, there are 4 stages. The 4th stage is the most advanced. The first stage is the early one. And when we talk about 1A, 1C, 1B, we are talking about disease which is contained in the ovary, not even spread to the tube. It must be absolutely just in the ovary. So it's very important to be sure that this staging has been done in the right way, in the best way possible, by means of all the scans and laparoscopy, and being sure that even in laparoscopy, when we do this, we are able to control all the sites that could be disseminated. I mean, I'm talking about not only the pelvis, but the upper abdomen, sometimes where we have isolated metastases just under the liver that might be very difficult to be seen also by means of scanner of imaging. So let's say that we are sure that the patient is at least 1A or 1C or 1B. And by 1A, we are talking about cancer in just one ovary. By stage 1B, cancer in both ovaries. And stage 1C, cancer in the ovary and on the surface of the ovary. Okay, so it's very important to understand that if it is 1C, we have also the very higher danger of having this tumor disseminating to adjacent to the organs which are just near or attached to the ovary. We know that on the left we have the sigmoid, we have the rectum, we have the uterus. On the right we have the appendix, we have the cecum, we have on the top of the ovaries, we have most of the time the bowel, which is absolutely attached to the ovaries and can really be involved in a matter of time. So it's very important to be sure that we are dealing with the stage 1 realistically ascertained and stage of cancer. So what would be the surgery? The surgery would be a unilateral salpingo-oophorectomy in case of stage 1A. It will be ovarian cystectomy. It could be bilateral salpingo-oophorectomy plus uterine preservation, or in certain countries of Europe, unilateral salpingo-oophorectomy plus hysterectomy with the use of surrogate uterus. This is, I think, quite improbable in Italy. It can be done in England, but not in France. So the surgical staging for all tumor types in apparent early stage tumors is mandatory. It's very important and must be done, as always, with the best techniques. So what are the RCOG, the Royal College of Obstetrics and Gynecology guidance for ovarian cancer? In this case, if we want to propose fertility sparing surgery, we must fully stage the ovarian cancer, remembering that normally we should take out also the uterus, both the ovaries. We should take out the omentum with a radical omentectomy or an infracolic omentectomy. We should do pelvic and para-aortic node dissection, and we should do peritoneal washings. And of course, we should take out all the sites of disease macroscopically detectable. The risk of microscopic metastatic disease on the contralateral preserved ovary is around 2.5%, according to the literature. 9 studies, which are encompassing around 507 patients totally, and dealing with fertility sparing surgery, showed a recurrence rate of 10%, 5% death from disease, and on the other side, 186 term deliveries, which is quite a good result. So the ESGO, the European Society of Gynecologic Oncology, came out with this recommendation. Stage 1A and grade 1 and possibly grade 2 tumors of mucinous serous and not clear cell tumor should be considered for this surgery. And we have other entities when we talk about ovarian cancer. Borderline ovarian tumor is one of these. Germ cell tumors is another one. Borderline ovarian tumor is well established as a kind of tumor that we can treat with fertility sparing surgery. I would say that it's the typical situation. We have a young lady with borderline ovarian tumor. The median age of presentation is around 39 years old. 5-year survival is very high, 97%, although we can have some recurrence from time to time. 5-year survival instead in stage 2 or stage 3, or in those patients presenting with microinvasive disease. I call microinvasive the one that has implants that are more than 5 millimeters in extension. This is an entity that is very well explained in the anatomical pathological studies. Those have a survival of 65 to 85%. And I would say that in this case too, we have to be really careful when we give information to the patient and when we're seeking her consent. Germ cell tumors shows a survival in advanced disease of more than 90%. And by the way, this is a very chemosensitive tumor. I treated a lot of young girls with this kind of situation, and I have to say that we have found it very feasible to do a fertility sparing surgery in these ladies. I think that we have to protect the fertility there more against the tumor, more against the effects of the chemotherapy. which will be for sure done and attempted. But this can be done quite easily today with some very good protocols that we have seen very doable with our fellows, fertility specialists in Edinburgh and also here in France. So the typical situation that we have there is an ovarian tissue retrieval with a cryopreservation. We can do also oocyte retrieval. There is a 3-5% successful pregnancy per egg. Contraindication, of course, in hormone-sensitive tumors, but this also is a matter of analysis. We are not completely sure that this is always true. The problem is that sometimes having to deal with another specialist, the fertility specialist, will need time to study the patient and to do its own part of the staging and its own part of the job. This might delay the treatment, so it's very important to be sure that in order to do this, we discuss the case maybe more than one time at the MDT multidisciplinary team meetings, so that we seek absolutely unanimity in if we have to delay the treatment. This is very important also for what concerns the legal issues that we can have after that. Study of ultrasound treated for all cancers showed 4% of the patient were seeking fertility preservation, 60% were concealed, and this had at the end an effect of treatment on fertility. So it's very important to know that they are very, very receptive, those patients. They are waiting for a solution for their problem, but they are still very, very anxious of knowing that they will have a protection of their fertility. So I just talking about this problem of legal issues and the problem of what is the typical path of the tumor. When we are dealing with a fertility sparing problem, we have to think that the MDT meeting is the right way to decide for the best treatment to propose to the patient, and who will be the specialists that are going to enter in the treatment of this. So normally the patient will arrive from the typical channels, which are the referral from primary care, general gynecologists or other specialty. They will have staging imaging and tumor markers and biopsies. They will be discussed the first time at the multidisciplinary team meeting with the recommendation for primary surgery or fertility sparing surgery. In Edinburgh, we were 5 gynecologic oncologists, and after that, the patient, or as a neoadjuvant, she will have chemotherapy and sometimes radiotherapy, or sometimes there will be nothing to do and she will be sent for palliative care. Of course, this is part of a bigger plan, and you can have here, I don't know if you can see well, there are patients in yellow who go for no surgery because of palliation or because the review showed that they were able to be treated by hormone therapy. Primary surgery in the green area, and in the blue, I showed the primary delayed surgery, which can be delayed because of also the situation of the fertility specialist who needs sometimes to get the whole situation under control. So in a snapshot of surgical cases that I did on my cases in 2018, just to understand what was the impact of fertility sparing surgery on my activity, I can tell you that endometrial cancer, we had 21 patients, 4 discusses fertility wishes. All of them had very, very important issues with obesity. This was a common theme in UK. Those who discussed fertility wishes had one of those had 4 failed attempts at IVF plus subsequent diagnosis of tumor. One had already a Mirena implant because she had abnormal bleeding. None of those at the end had fertility sparing surgery because they were not at the end completely convinced that this was the best for them. And after the consent process, they deny consent for fertility treatment. 9 ovarian cancer, there were 7 serous, 3 mucinous. There were mostly 1A and 1B. I had also 1C. 4 initially planned for FSS. 2 successfully had fertility sparing surgery. 1 had bilateral masses with bowel adhesions that was treated with the complex pelvic multidisciplinary team of which I was part in Edinburgh. None of them had at the end a pregnancy. The conclusion is that for cervical cancer, fertility sparing surgery is for sure feasible with acceptable outcomes in terms of perioperative morbidity and viable pregnancy rates. But the studies are warranted in order to clarify the risks of disease recurrence. This must be really clear nowadays. It's very difficult to propose from absolutely on the spot, to do a reduced radicality on a patient that can risk 6-fold times the relapse rate of if compared to traditional surgery. So we have to be really clear what we offer and how we offer it. Okay, so if we are going to do a trachelectomy, maybe there is nothing bad in offering a trachelectomy done by laparotomy. I don't think that this would be the problem. At the end, the patient wants a good outcome, and if she's really seeking for a fertility preservation and she wants babies, maybe at the end there is not so much to say, and she will accept the laparotomy. Fertility sparing surgery in endometrial cancer or atypical hyperplasia is feasible under certain conditions. It's a very, very situation of very important in terms of selecting the cases. Information to the patient and family is crucial. Pregnancy should be planned attempt once response has been confirmed. I'm talking about 12 months. And completion surgery should not be delayed. Fertility sparing surgery in ovarian tumors is feasible in selected cases of early stage, both in epithelial ovarian cancer and in germ cell histotype, with adequate information to the patient and family. In borderline ovarian tumor, fertility sparing surgery is well established. Advances in fertility and reproductive techniques are rapidly changing and will help in optimizing the offer and the outcome of FSS treatments to our patients. I would like to thank everyone for your attention. It has been really a pleasure to speak tonight. Thank you.
Thank you very much for this very condensed and very easy to understand the presentation. I'd like to ask Dr. Ahmed and Dr. Nassar if they are joining us now to share with us their valuable intel. Yes, are you there? Are you hearing me, sir? Dr. Ahmed? Hello? Dr. Ahmed? Dr. Nasser? Hello? Dr. Nasser or Dr. Ahmed? Hello? I think that Dr. Mario, we can't reach them now, yes or not? Do you see them, Dr. Mario? At your end?
Yeah, I can see. I was just checking the answers and the open questions and.
Hello.
Hello. Who's what?
Can you hear me?
Yes, yes. And Dr. Mustafa and Dr. Mari with
Hello.
you. Yes, we can hear you. Yes. Dr. Ahmed? Yes,
Hello.
Dr. Ahmed? Hello, we can hear
Hello.
you. We
You
can
can
hear you,
hear
sir.
me?
I
Yes,
can hear
yes.
you very well.
It is
Yes.
very, very valuable presentation. Thank you very much. I really enjoyed every slide of it.
Thank you. Thank you very much.
I appreciate if you can have a copy of these slides, please.
Of course. I think that you can have them through.
That'd be really very, very kind. Very great job and very
Yeah,
great
I can send it
effort
to you.
you have been spent on this presentation. Thank you very much.
Thank you. Thank you.
So, Dr. Ahmed,
would you
hello?
like your thoughts on the topic, please, from your side?
So
Hello?
I have one question for Dr. Mario, if I may. Hello?
Yes.
Yes?
Yes.
Okay, Dr. Mario, so you have said earlier that during ovarian cystectomy, we have to be more cautious about dealing with the cortex and ovarian cyst, yes, in order not to damage the ovarian reserve of the patient.
Yes, absolutely.
So how do you feel about
Dr. Mustafa, your voice is not really clear.
Okay, so is it now clear, sir?
For me, it's clear. For me, it's clear. Yes.
So how do you think about the hemostatics and the new modalities we have now, like, the fibrillar and this hemostatics? Is it safe to use, or it also affects the reserve?
Well, no, I think that it's a very good idea. I used it, but you have to understand that it can increase the level of adhesions. Okay, because I don't know if you had any chance to get back in abdomen, maybe because of a bleeding, and you can see what happens with those fibrillar. They sometimes move from where they were, and they just get out of the cyst beds, and they get attached to the bowel and or the ureter. So it depends what kind of dissection you have done to prepare. I mean, most of the time we don't have those cysts that I showed you in the picture. You have really an endometrioma with a big amount of adhesions. Once you have cleaned the ovary and you detach the cyst from inside, I understand that we need to avoid at the maximum coagulation diathermy, but I think also that there are some vessels which must be absolutely closed well, because otherwise you will have to go back in. This is not enough with those products. I think that the product itself for the small cyst will be really usable, but when you do a big dissection and there is a lot of areas that can potentially bleed, I don't think, because of the entity of the ovary, which is not really firm in maintaining the shape, you will have this material that you leave inside will go out, will spill out, will be attached to the tubes. And from the point of fertility, I don't see this as a definitive result.
So what about suturing? Do you
I never
advise
suture.
us to? You never do
I never
that.
suture. I never.
So we'll leave it.
I
open
never
as it
suture
is.
because suture is, in my experience, gives a 30% risk of relapse of the cyst.
Okay, this is good. So another one I had that you said myomectomy when you have several myomas, like 10 or 12 myomas.
Yeah.
So I had a technique that to move as much as we can from the same incision.
Yeah.
So do you advise us to use that or to open as much as we want?
Yeah. As you might remember, when we did those operations together, we had several fibroids to operate that day. I told you that, and I know that you had the same kind of actions. I think it's a very intelligent way to enter. If we have to take out 3-4 fibroids from the same site, this will be absolutely the best option that we have. Before, I think that it's very much important when we do any kind of surgery, but more and more when we do this on fertility, when we are there, either by laparoscopy or by mini laparotomy or by any other kind, we have to be sure that we stop a little bit, we do the right strategy, we decide what will be the right strategy. and we don't start the operation just because we are facilitated by the first fibroid. Let's have a look to where are all the fibroids, what will be the maximum amount we are going to do, and try to optimize the entry, the incision on the uterus, so that we reduce the number of incision. This is absolutely a trick. I have to tell you that we did some kind of experimental studies on the mouse, and on the mice's uterus, we could see that the repair that we were doing on the uterus by suturing it were at the end never perfect in terms of scar removal. When the suture has been completely absorbed, you will see that the fibrillae, the fibers of the muscle, will position themselves not as a continuous, but they will be just very, very arranged in a very disordered way. And I think that the best way to obtain a good result is to leave the muscle to heal by itself. So if we can put less stitches, this is better.
So laparoscopic myomectomies are not very good in the childbearing period.
Well, if we are talking about pregnancy, I think that you have to give the best in terms of resistance, and you cannot give that with laparoscopy. Yes, I think laparoscopy gives you a very, very good result in terms of aesthetic, and also technologically, it's really a good way to do that. But it has a lot of impairments in terms of giving the right resistance to the uterus.
Perfect, perfect. So, okay, thank you.
I can't hear you.
This all thing.
Dr.
No, I'm giving this the talk to Dr. Ahmed or Dr. Nasser. Hello.
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 Yes, can you hear me?
Yeah, very well, thank you.
I kindly just ask about the IVF, the like freezing the eggs, or in vitro maturation, or IVF freezing the eggs before the like oophorectomy, bilateral oophorectomy.
Yes. So you want to know exactly what kind of technique we propose?
Yes, please.
Yes. So what we propose to the patient is in 2018, we were proposing retrieval of ovarian tissue from the cortical, okay? And we would put the tissue in an ovarian bank, and we would have this tissue ready to be used at the occurrence. Now, I have to tell you that 90% of the cases are resolved by oocyte retrieval and vitrification.
Thank you very much.
So this is because I think that at least I have to tell you my most of the experience that I have with this is in Rome and in Edinburgh. In Edinburgh, by the way, the group of Professor Anderson was really really fantastic in the retrieving a very large amount of oocytes. And they had very, very good numbers in terms of cryopreservation and a successful pregnancy per egg. And those numbers that I gave you, these are coming from the Anderson experience. If you see it, this slide that I'm showing now, can you see it?
Yes.
It's Dr.
So
Nasser.
this is a slide that make a resume of the whole process at University of Edinburgh. But you can have this with the slides that I sent to Saudi German Hospital.
I think we have a questions from Dr. Mohammed Al-Fay. Dr. Mohammed was asking about the effect of cancer of the surrounding pelvic organs on the female fertility. what if have a bowel cancer, or we have another cancer, not gynecological?
Well,
What
this
about
is,
it affect the
yes.
fertility?
Yes, this is I mean, this is easier, first of all, because when we are called for such an expertise, for a consultancy for this, I mean, of course, the problem arises from our fellows colorectals mainly. When the colorectals calls us, what we see is uh, a spread of the cancer to the tubes, to the ovaries, and normally the surgery that are done by the colorectals are done all for quite advanced cases, you know. So it is quite difficult to decide for a fertility sparing surgery in that case, because normally we have already an impairment of the ovaries bilaterally. We have already dissemination, and those are not 1A, you know. So it's very difficult to talk about fertility sparing surgery when we are called to decide for what happens to the organs when another pelvic organ is affected, because this is already not a 1A. You understand? It's not a 1B. Yes. It's not a 1C. It's already at least a 2B, which is not entering in that classification of fertility sparing surgery.
Perfect, perfect.
Dr. Nasir, we would like to have your comments on this.
I'm sorry, Mr. Subit, there was a problem of the communication. I missed a good deal of the presentation, so I would like to apologize for that.
No problem, Dr. Nasir. So that would be great if you can share your thoughts, you know, something about that topic. If you have any questions, Professor Mario.
Yes.
Well, actually, I have something, but it's not related to our topic. If I may ask, what do you think of the best treatment for a patient with suspicious of leiomyosarcoma? Would the lymphadenectomy be a requirement in such cases or not?
Ovarian?
No, leiomyosarcoma.
Leiomyosarcoma. Lymphadenectomy is not indicated.
Thank you.
Welcome.
Okay, I think thank you, Professor Mario. Thank you, Dr. Mustafa, Dr. Ahmed, Dr. Nasir, for joining this webinar. And for the audience, after the webinar, you will get a link, you know, just to share your feedback onto the webinar. And
thank you very much.
To the audience, you know, we are conducting the webinar with our international professors on every Sunday at 9 p.m. Saudi time.
Yes.
Our webinar is one of the plastic surgeon from US, and that would be on 30th of August at 9 p.m. You will get the link for that webinar on your email, and yeah, hopefully we would expect you to join the next webinar as well.
Thank you very much for the invite.
Okay. Have a nice day.
Thank you.
Thank you.
Thank you.
Thank you,
everyone.